Julio.
Hello, Paulo.
Can you hear me? Okay. Thank you very much. Thank you, Terry, for this very interesting lecture. And I think that we are ready, so you can ask difficult questions to Thierry after a while. We are ready for the next and the last session for today, and we are ready to connect with Florida. I see that Shyam Varadarayulo is ready to perform the first case, so we start presenting the first case in that will be performed in the Florida Hospital Medical Group by Shyam and his group. So we go to present first the case.
Next patient live from Orlando is a 90-year-old male with a medical history of thoracotomy for a large emphysema and multiple abdominal surgeries with partial colectomy, vascular reconstruction of mesenteric vessels. The patient presented with phangemia and septic emboli to multiple organs, and it was seen a 6 per 8 centimeter elongated mediastinal abscess tracking to the retroperitoneum. Interventional radiologist guided drainage failed, and the patient is a high-risk surgical candidate. Today's scalp procedure is EUS guided transesophageal stent placement requested for abscess drainage.
Good morning, Paulo and Julio. Such a pleasure to be here from Orlando. So you heard the first case. This is pretty much a very straightforward patient with a mediastinal abscess. He had a CT-guided drainage that failed a couple of days back, and he's got multiple episodes of fever and chills and rigors from septicemia. So the problem with radiology was that they had an interposing left atrium on the lung along the path of the needle, and they could not get a safe window. So I got my linear scope in the esophagus, and if you're having EUS on your screen, you can see that I'm at around 33 centimeters. Those are the tracheal rings. Here is the subcarinal space, and as I slowly torque my scope back, I find the aorta with a lot of calcifications in the aorta. And then here you see the collection, which is what they are referring to, the mediastinal abscess. I was concerned it's going to be a lot of solid debris, but it looks quite liquefied with cyst contents. So this is the plan is not to place a luminoposing stent because it's via the esophagus. So we need a smaller opening, and all that we need is a decompression point. So we are going to first start with a 19 gauge standard FNA needle to access this collection and probably to get some fluid for microbiology. And then we will perform a dilation and hopefully a stent placement.
Hello, Shyam. It's always a pleasure to see you working from Florida. What is your stent selection in this case for a mediastinal access?
Stent selection is always plastic, Julio. We never place a metal because we do not have the 6 and 8 millimeter stent that you have. And I think all of these patients always have pneumomediastinum after the procedure. That's our experience. No matter what precaution you take and how less you dilate, and let's go remove the stylet and put suction. No matter what you do, they always have pneumomediastinum after the procedure. So the plan is always to dilate no more than 6 millimeters in these patients and place a couple of maybe just a single 7 French stent or maybe 2 7 French stents. So you can see here, Julio, it's very clear fluid that's coming out. I don't see much. It does not look very sanguineous, or it does not seem to be having much pus contents in it. So I've got a 19 gauge needle, and now what we're going to do is to pass a 025 guide wire to coil within the collection. And I also generally tend... Go on now, Julio.
No, we're just asking the audience because it's not so common to see a draining and mediastinal access AUS guided, so it's a very good opportunity. If the audience has any question for you, Shyam. So you told us that you will go for just one double pigtail stent at the or try to get 2 stents.
Yeah, I will try to get 2 cents. The problem, Julio, there you can see on, can we show fluoro and fluoro on the screen to the audience? And we can have the camera and we can show the EUS image on the small screen. So let's coil the wire. Fluoro, let's go. So it's, as you can see, Julio, it's tracking somewhere down. I have no idea where the wire is going. So let's go down on that wire. The thing that you don't want is the wire to coil somewhere in the mediastinum. So at least it's taking a turn. It's going all the way down and taking a turn. It's a very elongated collection. And at least it's coming back towards us. So, all right, let's. It's a season of Lent. You should do your prayers. Let's exchange. And we're going to lock the needle and exchange this. One of my concerns always in mediastinal abscess is the use of cautery for creating the tract. They get a terrible chest pain after the procedure. And then when you do a CT scan, it's almost always invariably read as a post-procedure intervention causing a pneumomediastinum. But that is very expected of the procedure. So let's take it out. And then let's have your cap back.
So you have the patient intubated to do this kind of therapeutic procedures, Saihan? You prefer to have
Generally,
the patient intubated, or you can see it can be done just in deep sedation like propofol without intubation?
Julio, to be honest with you, I did not expect this amount of liquid. So I thought it's going to be a little solid when we looked at that scan. So I told them I don't expect a possibility of aspiration and so on. So this patient is, to be honest, being done under deep sedation. But generally, we always do drainage procedures with a general anesthesia. So this is a one-off procedure. So we should probably try going straight with a balloon. Julio, we always use a cystotome to gain initial entry. But as you know, the esophageal wall is so thin that generally just going with a balloon might be possible. It's only 2 millimeters in thickness. So your sharp balloon will find its way, I think. And our plan is to just dilate it and then try to use a 7 French stent introducer, and over which you can pass 2 guide wires, and then sequentially you place 2 7 French stents. One of the problem here is once you place a 7 French stent in the mediastinal abscess and it decompresses, it generally moves away, and the second wire is so difficult to find its path into the fluid collection, and then you just keep coiling around in the mediastinum. The catch here is to get that wire, get the balloon down as close as possible. And then I'm going to have Enrique give me a lot of tension on the wire. And then we are hoping that with mechanical tension, we will find our way in. The trick here is to perform the whole procedure with EUS guidance at this point, just because you want a close opposition of the balloon to the esophageal wall. So we are almost at the bottom. Can you show me fluoro, please, for a second? I need to see if my balloon is coming out. Yeah, there we are. And there with EUS and a little bit of tension, we're going to see if we can just drive ourselves. You can see tinting, and generally you shouldn't see tinting. Can we remove Doppler off the color flow? So I'm going to pull back the balloon and then bring the collection into view again. And then can you give me tension, Enrique? A lot of tension on that wire, a lot of tension. And you can see buckling right away. So this is the second time. What you do not want is to cause a shearing at this point. You might as well just use your cautery device if you're having so much movement. So I'm going to, so a little bit of tension. So that's not going to work. So once we see this, you generally quit back. Let's exchange again, and let's get the cystotome. You can see that, Enrique, Julio, that there's really not much of an opposition between those two structures. It's not like a pseudocyst where it is, well right against the gastric or the duodenal wall with a lot of inflammation to anchor this collection. Every time you do something, it tends to move away from you. I think aluminum
Which is
posting
you
stent would
make
be
most of your movements and most of your technique is based on AUS imaging. I mean, with you just use X-ray from just when you inserted the wire, but most of the time just to have everything in a good position, you're basically doing an AUS guided procedure.
That's correct. I mean, I think fluoroscopy may be okay. The thing that should not be done is to try to rely on endoscopy view. Usually when you try to see on endoscopy, that's one problem happens. We have a tendency to move away from the collection, and then the tip of the transducer is elongated, and then we will move away, and then the guide wire coils in the space between the fluid collection and the esophagus into the chest cavity, and then it becomes a disaster. So you should try to do everything with the EUS. It's okay to have some fluoroscopic assistance, but it's very critical not to depend upon endoscopy at this point because you've got the left atrium right next to it. So I've got the cystotome down almost. Okay, we're coming down. So Enrique, it's important to just give me a complete traction. Fluoro, please, and then with my position there, we are going to just use cautery to gain initial access into it. Just one small button, I think we're going to go right on. So fluoro again. I think I'm in. Yeah, we are in. So you can see, Julio, it just tends to buckle away from you. So we are now deep in. There is no need to do anything else. So we'll now exchange and go straight for the balloon. Usually I go back and forth with the device, pull me back in, just because you want to mature the tract and make your process of entry with the balloon easier, because the balloon is a little more wider than the cystotome. So if you don't go back and forth, you will start buckling once again. So the second process of the second part of the procedure is done. The third step is going to be dilation to 6 millimeters, and then we will deploy a 7 French double pigtail stent. The thing, Julio, is this is not going to go away completely. I'm not very naive because this is a collection that you can see tracking almost all the way down somewhere in the duodenum. It is very naive to think that a small 7 French stent in the esophagus is going to drain all this fluid miraculously. Even a 7 French drain is not going to do the job. We are just hoping to get to decompression so that he doesn't have his septic episodes. Because I think there was question of an embolic foci in the brain. So he was having a lot of confusion and so forth. We don't have a hurricane balloon, is it?
But do you think we should start to think in an AUS guided as a primary option when we have these mediastinal accesses, or we should keep AUS as a second shot attempt and trying to go with the standard with the radiologist? What do you think is going to be the place of AUS guided drainage in mediastinum?
I think the problem is, I think the procedural safety may be comparable. Fluoro, please. And then we're now trying to pull me in. Okay, we are in, I think. Does it have a radiopaque marker in this? It does, huh? Can you mag me up? I think I'm deep inside, but I don't see it very well with fluoro. So where is the marker? So, there it is. Let me come out. Sorry, I can't see the fluoro marker, Julio, so I'm just going with endoscopic assistance there to just make sure my balloon is in. And that is my balloon. Pull me back in and pull me back. Yeah, I'm in. So now there is the marker. Right, we can see it on fluoro. Okay, I'm going to pull back. All right, let's dilate this. I think this is not a problem, Julio, with this procedure. The thing is, if you put in a drain for a lot of these patients, it comes out through the nose, whereas with radiology, it comes out somewhere else. It's comfortable. The second thing that we have to be, oh, yes, let's go dilate all the way up. So the second thing that we have to be cognizant of is we have to accept a little bit of pneumomediastinum, like the way we accept a little bit of free air when we do drainage procedures. We don't sweat a lot. We are okay with it. Let's go with fluoro, please. And you can see on EUS, the balloon is slowly inflating. So we have to go all the way up. Okay, I think the balloon slipped in. Can we deflate a little bit, Enrique? See that? It slipped in a little bit. I'm going to come back, okay? deflate fully so that we are not shearing the wall of the esophagus. There we go. I'm going to pull up a little bit. Up. Okay, let's go again. So I'll give negative traction as you do. There we go. Perfect. Yeah. So on fluoro and on radiology, we can see that we have reached the point of maximal dilation.
I think one important message for the audience is sometimes we think that these procedures should be more endoscopic guided than AUS guided, but at the end it's important to see that it's very important to have AUS image while you're doing these procedures because it's going to be more secure, not to be too much separated from the esophageal wall. It's very important to keep this under AUS guidance because you're going to decrease the probability of complications, at least until we need to deploy the stent decided by the endoscopy.
Yes, I think once we see the stent, the distal portion of the stent going in, that's when I think we have to go to endoscopic view. We have to resist the temptation until then, because early on in our careers, we always get very concerned. I'm just going to go back with a balloon and make sure my tract is nice and open, and yeah, it's going out very easy now. So I don't think I'll have a problem getting a stent in. So let's exchange. Okay, perfect. So we'll have a 7 French stent with a 4 centimeter double pigtail with a mark exactly in between. Okay, out.
Saham, what do you think about, because we know there is a lot of indication for hot access. There's a couple of papers coming from Spain, case series about using hot access in mediastinum. So what you still think, do you think that in the future with the development of small hot access there will be an option to drain these mediastinal abscesses with a system like hot access?
I think, I don't know, Julio. I mean, I've had some cases of buried stent syndrome. And I think in the stomach, we are okay with the buried stent syndrome. It didn't happen too long. It happened about like 3.5 or 4 weeks. But in the esophagus, if my stent buries, I think we are going after a thoracic surgeon to bail us out. So that will be my major concern. But I think if you tell me in the US, we don't have a 6 or a 8 millimeter. But if you give me a 6 or a 8 millimeter for this procedure, I might be okay with it. I might be okay with it. And the second is, I do not know the ramifications. In the stomach, I think once we are left with a big cavity, if we have food going in or we are having some foreign body going in into the pseudocyst cavity, it may not be a big thing. Even into the gallbladder, sometimes this happens. We don't worry too much. On the other hand, if we are having food particles in the esophagus, because that's where you eat, the channel is small, invariably there's going to be migration of things that we drink and what we eat to go into the chest cavity. If you're having a big luminoposing stent, that would be a little bit of a concern, I would think. And also you can have a foreign body impaction. If the cavity collapses and the stent is now in the mid-esophagus, and if you're going to eat something, there's a very good chance that a chicken bone or a fish can get hung up on the luminoposing stent. And when you're trying to extract the foreign body, we can cause a perforation. Probably, I think if it is being done by somebody who does therapeutic endoscopy all the time, it may not be a problem. But I think it cannot be a one-off procedure. We have to be, at least we know the problems we may encounter. Then I think we'll be fine. But being unprepared could be a serious issue. Because I've seen when I was running CGH journal, one of the endoscopists in the US, he reports a lot of complications, presented a case of an esophageal stent removal. And when he removed the stent, Julio, the whole esophagus came out. I mean, it was a huge picture of an esophagus with a stent in the middle. So sometimes these things are a little worrisome. So fluoro, please. I'm doing everything under fluoroscopy and endoscopic view. I don't have my stent down yet. So a little bit of tension on the wire, Enrique, because you can see the cavity is big and the scope is straight. It'll be funny if the stent just goes in. If the stent goes in, Julio, there's nothing we can do at this point. I mean, it'll just migrate deep down into the cavity, and then you have to preserve the wire and just deploy another stent by the side. So I'll have to be a little careful. Keep pulling me. I think I'm feeling something coming now. Maybe the stent is going to come out in a second. Not yet. Okay, maybe. Yeah, see, I did not even feel the stent going in, Julio. It just went straight in. So let's go to endoscopic view. And is that in? No, not yet. So the stent is now going in a little bit more. There we are. Okay. Now I'm going to just, this is the point you need endo view a little bit, because you want to see this. Because Julio, this will just drag in. It happened to me once that the stent just dragged in. It just went straight in. I didn't push anything. And then it just migrated. So I'm looking for my marker, which is a black mark. And there it goes. There it is. And then once I see this, I'm going to let go of my elevator. And I'm going to have Enrique pull. Yeah?
We don't have the endoscopic view.
Can we have the endoscopy, please, on the screen?
Okay, now we have.
Yeah, it's a bad view. Yeah. And then I'm going to, that was my black mark. I'm pulling my scope back. I'm somewhere at 22 centimeters. So it's not very far from the esophageal sphincter. Enrique, can you pull the scope back a little bit? See that? I'm just going to come out of the sphincter anytime. So I don't want him to feel this in his throat. So I'm going to push it in. Okay, wire out, please. And then that's it, we are done. So let's go back and see how it looks. Yeah, so it's hanging there, hanging right there. So you can see the challenge in getting a second stent right by the side of it. It's usually very painful. Ideally, you're much better off going with a gastroscope and finding. But I think given that the fluid is so thin and it was draining pretty well into the canister, we drained about 200 cc's. We're just going to leave this alone, admit him to the hospital, get a CAT scan within a day or two. So that is the collection.
Okay.
And then yeah.
Shyam?
Yeah?
Shyam, thank you very much for this great demonstration. We're now going back to Milano and we are going to present the next case. See you in a while. Okay.
Okay, thank you.
Thank you, Shyam.
Next patient is a 62-year-old female with a medical history of cholecystectomy and uterine fibroma. In January 2018, the patient had weight loss and abdominal pain and underwent an abdominal ultrasonography showing a common bile duct dilation. Blood tests showed a slight increase of transaminases, gamma-GT, and alkaline phosphatases, and also a slight increase of CA19.9. A CT scan showed a 15 mm solid lesion of the pancreatic head uncinate process and common bile duct and pancreatic duct dilation, and a lateral contact with SMV for the lesion. Today's scheduled procedure is EOS and FNA and ERCP with common bile duct drainage with operators Dr. Santo and Dr. Opong.
Hello, everybody.
Hello, Erwin.
So we are back again. So you heard the story of this lady. We are using for examining her tumor. We are using the Olympus interventional scope with the new Arietta machine. And we are positioned in the second part of the duodenum. As you can see here, we have the inferior vena cava, and we see the aorta here. And you can also notice that even from this position that we have some lymph nodes here, just adjacent to the vena cava. And if we move a little bit on to see the head of the pancreas, we immediately see this lesion that it's immediately discernible from normal pancreas. This is this hypoechoic lesion here, which appears to be more of a periampullary lesion. It's in the periampullary area. We measured it before. It has irregular borders, and the size is around, the biggest diameter is around 2.3 millimeters, 23 millimeters. As we go on here, you can see down here you can see down here that we are quite adjacent to the superior mesenteric vein. It's a little bit difficult to see, maybe we'll give it some more gain. And the tumor actually goes down to the vein. I don't know if you can see it very nicely, but very clearly. But in this area here, we didn't see a demarcation line. So it's actually a tumor is touching the vein, and I think that we can say that it might be that it's even penetrating, but it's too far away. It's a little bit dark. It's difficult to see, but our impression was that we have an involvement of the superior mesenteric vein here, at least part of it. You can see it now maybe better. And if you put some Doppler on it, sometimes this helps you define the borders much more accurately. And what I think that we have here, we do have some involvement of the superior mesenteric vein. What do you see?
Just a question. Do you think contrast enhancement is not only useful for the differential diagnosis or characterization of these kind of lesions, but do you think that might be a role for contrast to optimize staging, vascular staging of
yes, sometimes when you have a problem like this and you are not so sure, I think the contrast can help you a little bit just to delineate much more clearly the borders of the vessels. And well, usually I think in the everyday routine it's not so commonly needed. But in this case, what do you think?
No, I agree with you, Erwin. I mean, there are occasions when it's helpful, but I think you've demonstrated it quite nicely. It looks to me like it's not just in contact. There's a loss of the interface, and I think it's probably eroded. It's not distorted the vessel, but it's definitely loss of interface and involvement.
Yeah, absolutely. So we just pull back a little bit, pull back more, and now we see again the tumor quite nicely, and you can also, I think, see that there is some penetration into the duodenum. I didn't see any involvement of the duodenum when I went in, and this is due to the fact that I think it only involves the inner parts, maybe the muscularis or submucosa, and doesn't get into the lumen itself. But definitely, you can see here that the duodenal wall is involved. It's also difficult to see the ducts. Also, although we saw the Wirsung duct, I tried to demonstrate it to you. It's included in the tumor. It might be this one here.
Yeah, but this is a good demonstration of the ability of AUS to really evaluate the vascular infiltration of pancreatic cancer. There's a lot of studies trying to compare AUS plus multi-detector CAT scan, and at the end, we all know that it's complementary, but if you make it really dedicated, AUS to try to see deeply these pancreatic solid masses, is very, very helpful, and is as useful, or in good hands, even more useful than a CAT scan to determine whether the lesion is locally advanced or borderline, which is key for the decision on the management of these kind of tumors.
I completely agree with you. I think these both modalities are complementary, and US especially can, I think, clarify the situation when it's not really clear whether the vessel is involved or not by the CT scan. So here we are in quite a good position to take some biopsies from this lesion. You see the lesion is much bigger than was described by the CT. Actually, can we just a second? Let's move on a little bit. I just want to.
Which is also very common. I mean, in all our routine practice, I think we all see when we do the US deletions a little bit bigger than it's reported from the CAT scan and the MRI, mainly from the CAT scan.
Please? Okay, now you see the tumor here. I think the tumor extends from here, which is the duodenal wall, from up here. Sorry. No. Can you clear it? Okay, you must excuse my measurement mistakes because it's the first time I'm using this US machine, but it's at least, as I said before, it goes up to 23 millimeters, so it's bigger.
It's bigger, yeah.
It's irregular, irregular borders. We showed before that it's not vascular. And if you want also to use elasto, so can you make it bigger a little bit? More, just to include more of the tumor. Okay, that's good, that's good, that's good. Okay, so now you have an impression.
You should make the area a little bit bigger.
Okay, I have
A
some.
bit lower, yeah.
Okay, now it's better. Now it's better. Still,
Huge.
the picture is not
It
that
looks
stable.
like a stiff lesion, at least
it's
based on the last
dominant.
evaluation.
It's
Okay,
it's absolutely a
Ponti,
stiff lesion.
So, Erwin,
Yes.
so you're facing a hypovascular stiff lesion, so I think that you are going to biopsy
Absolutely.
the lesion. While you are preparing, we present the next case.
Okay.
See you in a while.
Next patient is a 71-year-old female with a medical history of appendectomy, cholecystectomy for lithiasis, HCV-related cirrhosis, and esophageal and gastric varices. In 2007, for an episode of biliary acute pancreatitis, the patient underwent MRCP, showing a common bile duct dilation in papillary stenosis suspicious and sludge. He therefore underwent ERCP with a sludge removal and papillary biopsies that showed chronic inflammation and focal moderate dysplasia. A common bile duct brushing was non-diagnostic. In December 2017, the patient came to our emergency room for cholangitis, and abdominal ultrasonography showed a biliary duct dilation, cirrhosis, and a 15-millimeter stone in the distal common bile duct. ERCP was performed with a papillary region into a diverticulum. At cholangiography, there was a common bile duct dilation with a 25-millimeter mobile stone. A double pigtail stent placement was performed. Today's scheduled procedure is ERCP with laser lithotripsy. Operator, Dr. Mariani.
Good afternoon.
Good
As
afternoon,
you
Alberto.
can, do you hear me?
Very nice.
On the right part of X-rays, you can see a large stone within the common bile duct. Before the RCP, we have extracted the stent that was in place because patient was submitted to previous ERCP with the intention in order to remove the stone. But in the present section, he would like to use electrohydraulic lithotripsy to treat this difficult common bile duct stone disease. I entered the common bile duct with the spyglass, and now I am trying to identify the large stone. X-ray. Have you the spyglass image?
Yes, we have. So now you're located in, just trying to find the stone, Alberto, correct?
Yeah, right. Scopia. We can see some fragments, but not yet the large stone. Scopia. On the X-ray, I am at the level of the stone. Inspiration. X-ray. I try to go upstream the stone and then go down. Scopia. Cholangioscopy. Scopia. Scopia. Cholangioscopy. X-ray. We are in front of the filling defect, but without a vision, the vision of the stone.
How do you find the spyglass system to move inside of the dilated CBD? You think it's an easy tool to and a good indication in these cases of big stones, Alberto?
I don't heard. Sorry, possiamo alzare il volume?
I mean, how easy or how difficult is to use the spyglass in this dilated CBD with these big stones? How is this to manage and to use the spyglass in these indications?
Because we have before used a large dilation of the papilla without any result. The patient had a diverticulum near to the papilla, and after the failed attempt with the conventional stone removal and biliary big dilation with a balloon of 15 millimeters, we decided for this treatment. Scopia. I have no problems with the spyglass. Scopia. Cholangioscopy. No.
Here it is.
Fragments. Aspiration, please. Aspiration. Scopia. Fragments, but downstream the great filling defect. Scopia. Okay.
How many in the audience are using the spyglass for stone lithotripsy? Have you tried, or those
Scopia.
people with experience in the audience, do you have any experience in the pancreas to try to make some extractions of broken stones in the pancreas?
Scopia. Cholangioscopy. We try to change the direction of the tip of the spyglass, but without any result. Scopia. Cholangioscopy. Scopia. Cholangioscopy.
Alberto?
Yes?
Okay, while you are trying to find out the stone, we move back to Erwin to show the biopsy.
Okay.
Okay, see you in a while. Erwin?
Yes.
Okay, here you are. We have seen that you have performed the first biopsy. I can tell you that it's very bloody, so
Yeah,
Professor Doglioni would prefer to have a second pass. So please go ahead.
Okay, so I'm using, so coming back to the issue of which type of needle and how we are going to proceed for solid lesions. In my opinion, since the appearance of the FNB needles, I think for solid lesion, definitely my choice, my preferred choice will be an FNB needle always. So I changed also in my department, I think the policy. We are using only FNB needles for solid lesions. Okay, now the needle is being prepared again. We don't have Professor Doglioni, unfortunately, with us, and we don't have any other cytopathologists in the room. But since we have been using the FNB needles, I think our yield has gone up, and I think this should be, at least in my opinion, the policy. For solid lesions, go with an FNB needle. For cystic lesions, we go with the regular FNA needles. So this is my view of things. What do you think?
No, absolutely. No, we've done exactly the same. Our pathologists are very happy with the tissue we get with the shark core, and so our policies, we just do three passes into the formaldehyde, and we don't have any in-room cytopathology, and we only use the cytology now for, as you say, cystic lesions, and we're just actually completing a study comparing FNB versus FNA.
So what you can see here, you see the tumor here, and you see this big dilatation of the Wirsung duct, of the main pancreatic duct. This is supramesenteric vein, and that's it. And now, because the first pass was bloody, we are going for another one. We are using the acquire needle by the shark. Sorry, we are using the shark needle by Medtronic.
So, Erwin, whenever you get a bloody sample after the first pass, do you make any change in your technique for US-guided tissue acquisition? Maybe you stop using suction, you change for slow pull, you just don't use anything? What's your approach when you have a bloody sample at the beginning?
When we have a bloody sample at the beginning, it depends why it happened. Usually, I don't know, for my pathologist, it's not a problem. And when we are doing these pathology samples, actually, it's not a problem. Because the blood doesn't interfere. It might be interfering in the cytological evaluation of the specimen, not in the biopsy specimen. So I think we won't change our approach. We will go again for another pass in here. We find this needle very, very nice and no problems at all getting into the lesion. You see the needle there, the needle tip. I'm trying to target the area which is just at the junction of the change of the diameter between a regular pancreatic duct and dilated duct. That's usually where the chances are to get most of the tumors. So here we are. It's a little bit difficult to see the needle, but you can see maybe now
Yes.
the needle moving. Okay, so can you remove, please? Now we attach a syringe anyway. And please warn me if some blood is coming. Okay. We are quite deep in here. It might be a little bit difficult to see the needle moving. You can see the upper part of the needle.
You can just see it in the upper part of the lesion. I think it's in.
Yeah, it's in.
Yeah.
We're definitely in the lesion.
Yeah.
There is no doubt about it. I think it's in the lesion. I will come quite high up. It goes very, very smoothly, and this is one of the characteristics of this type of needle. It's a very, very easy to go through even most fibrotic lesions. And I also found that we used to take at least to make at least 3 passes with the FNA needle when we didn't have a pathologist in the room. I think with this type of needle, 1-2 passes are sufficient.
And I must echo your comment about how easily it goes through the lesion, because the study we're doing, the patients are having both FNA and FNB, and our experience has been that the FNB needle goes into the tough lesions much more readily than the FNA needle.
Sure. This is my...
Just a question for you, Kofi. Kofi, you're using formalin, or as I understand, or you're using cytological solutions?
No, we're using formaldehyde.
And if you're using formalin,
Yes.
have you tried before to use cytolite, and did you see any difference?
We didn't, to be honest. I mean, from the days when we used the Procorn, I think, as you said before, it really comes down to the pathologist's preference. And our pathologist just wanted us to put it in the formaldehyde. So the FNAs will go into the red solution, but for histology, for the FNB, it just goes straight into formaldehyde.
I must say that it was a very important point. You should always consult with your local pathologist what is his or her preference. In our place as well, they want us to process it in formaldehyde. So all the FNBs are formaldehyde like any regular biopsy. We don't take any smears with this type of needle.
Coffee? Erwin, coffee?
Yes.
While we're waiting for the results of your biopsy, we go and present the next case. Thank you.
Thank you.
Next patient is a 66-year-old female with a medical history in 2016 of neoadjuvant chemotherapy followed by R1 duodenopancreatectomy for pancreatic adenocarcinoma, followed by adjuvant chemo and radiotherapy. In 2017, the patient had an episode of cholangitis for the biliodigestive anastomosis, treated with bilioplasty with biliary drainage. In 2017, the patient had an abdominal hernia repair. And in September 2017, an MRI showed a solid lesion medially respect to the gastric body, suspected for lymphadenopathy, although FDG PET was negative for pathologic uptake. A follow-up MRI in October at the beginning of 2018 showed an atrophic residual pancreatic parenchyma, pancreatic duct dilation, and a solid lesion in the mesenteric adipose tissue between the gastric body and inferior left kidney pole, suspect for recurrence, and a 5 centimeter fluid collection, probably for the abdominal hernia repair, and mild ascites. At the beginning of March, the patient had an EUS showing a 15 millimeter hypoenhanced and solid lesion between the gastric body and inferior left kidney pole and a jejunal tract. FNA showed adenocarcinoma. The patient is scheduled for radiotherapy on the solid lesion after fiducial placement. Here you can see the lesion. Today's scheduled procedure is EUS plus fiducial placement with operator Dr. Sahai.
Hello, everybody. Good afternoon. I just want to thank again Paolo and Erwin and Julio for inviting me. It's always a great honor to be here, and it's always an amazing meeting. The transmission is always super well done. So this is a really interesting case. It's sorry, the pointer is here. Okay, I'm not too familiar with the system, but so you can see and normally I would show you some anatomy, but this lesion is so hard to find. I don't want to lose it and then come back and spend half an hour trying to find it again. So here's the lesion we're talking about here, and I think this lesion is. We're wondering if it was coming off a loop of bowel, and what I'm wondering is, it sort of traces. You wonder if this could be a loop of bowel with a lumen here, and here's the lesion, which is actually an implant over the surface of a loop of bowel. May or may not be. See, there's a little bit of ascites here. Remember that, and this is the gastric wall, it is never normal to see ascites around the stomach. You can see ascites in between just under the liver from the bulb. That can be normal, especially in biliary obstruction. But if you ever see free fluid around the stomach, it's never normal, and you have to find a reason for it. And in this patient, obviously the reason is she has carcinomatosis with this peritoneal implant. So we're gonna use this fiducial device from Cook, which allows us to put in multiple fiducials without taking the needle out of the scope, which is a good idea because the old way where we would put the fiducial in the tip in this semi-sterile endoscopy sterile, which means very dirty procedure, was really not a good idea. We actually had a case of a liver abscess, I think, from infecting, putting multiple things in this thing. So this allows you to put the thing into the scope and never have to take it out again before you've put in the fiducials. So I'll take the needle. So we don't do a whole lot of this. I don't know if people are getting a lot of requests for this. I get the feeling that the radiologists they're sort of just using it whenever they think it sounds sort of interesting. I'm not very familiar with the data on whether this is actually helpful for really any indication in GI. And from what I understand... Sorry?
No, I've just discussed about the question you're asking. I've just discussed with my radiotherapeutics in Santiago about the indications for fiducials. And if it's a very clear lesion, very well located, with the new devices that they have available, they really do not need to have a very good marking because they can do it based on their systems. But for this kind of strange located lesions in relapse, they really found it very useful. And this is one of the pure indications that our radiotherapeutic agents are really
I can't hear you super well, Julio, but
it is very difficult to locate lesions.
I'm just wondering if does it actually improve outcomes? Are there any data showing it improves outcomes? So that's what I'm sort of curious about. So this is a 22 gauge needle. From what I understand, you don't have to put it, like exactly in 3 in a triangle or anything. They just need it to be in 3 different areas in the same lesion, and then the computer can use that to target the radiation. So this system is a 22 gauge needle. It's got 4 fiducials in it, separated by a little bit of material, and the needle itself has a groove, and as the fiducial comes out, it spreads the groove, and then when it gets to the spacer, which is not metal, the groove closes, and it cuts out the fiducial and deploys the fiducial. So you have up to 4, but usually we put in just 3. So I'm going to put the needle in now. Should be fairly easy to see. Yeah, it's a nicely visible 22 gauge needle. So I'm just going to go anywhere I can for now. What I'm concerned about is that this is going to be very mobile. So let's try and go in. So I went through it. That doesn't help, whatever that was. Okay. So I'm in here in a pretty good position. And this feels quite soft. So I'm just going to try and push this out now. Oh, you can see something coming out. I'm going to just use the stopper here so I don't go too far. Okay. And I'm just going to push this out. It's getting a little bit of resistance. And I felt a little click there. So I think it's in. Usually you can see the fiducials as well. So now I'm going to pull out and try and go somewhere else. Can I see the fiducial? Yeah, sort of. I'm going to say it's exactly right here. I think that's correct. Okay, so now I'm going to try and go maybe deeper in this lesion. But remember, I think this is, and I may be totally wrong, but I think this is lesion over the surface of a loop of bowel or something. So this isn't lesion. This is probably GI wall or something. So I put one here. I'm going to maybe try and put one deeper here. Okay. Whoops. See, it's quite mobile. I'm going to get this arrow out of the way. So I'm going to do the Rob Haas shish kebab technique, which means you just go really deep and then look for your tip. And there you go. As a general rule, when you put the needle in and you don't see the tip, don't keep pushing. Pull back. Because people tend to push in and they end up going really far. So I'm deep down here now. So I'm going to try another one here. I'm going to lock this up here so I don't push it out too far by accident. Okay, pushing. I feel it moving. And I feel like another click there. So I'm going to pull out, and hopefully I see another fiducial here somewhere. Yeah, not 100% convinced, but it's got to be there because I felt it come out. So I'm going to try and put another one.
And then do you think there is a need to have X-ray when you're placing fiducials?
I hope not, because I don't have any. But we never use fluoroscopy. But I assume it would make it'd be a little more certain to know whether it's in for sure if you had fluoroscopy. Okay, so I'm going in here. So I'm going to try and go in a third place, like right. Whoops, what did I do? Right about here. So I put one here, I think. One I believe is in here. We may not be seeing it because it may be kind of in the white part here. And this one I'm going to try and put right here. Okay. Lock this up here. Here we go. Pushing it out. And I felt the click. So it's got to be out. I'm just, not seeing it super well, but I've got to assume it's there. You think I should put 4 just in case? Do you think I should put the 4th one just in case, or just okay? So we'll do a 4th one just to say. Okay, so I'm going to just kind of go maybe more deep here. Okay. Okay, I felt that come out. So it's done, and I've got to assume that they're all in there. And I suppose we could check by making sure there's no fiducials in the needle. And if I can just, so if we can look around, I suppose if I put the gain down, it might make, I think we do see one. Yeah, Julio, I think the fluoroscopy might not be a bad idea in the future. But I'm pretty sure they're here. I mean, I think there's one here. There's one right here. The other one, I think we did see it originally quite well. The third one, I think might have been a little bit too much in this white business. And the 4th one, I believe, should be around here somewhere. But I'm pretty confident we got them all in. And just to show you, here's some more ascites here. It can take some time to find the ascites, but when you see free fluid like this is an amount of ascites they can miss on a CT, but it's an extremely strong predictor of carcinomatosis when you see that on EUS. And just to show you her anatomy is a little bit difficult because her vein is here as I torque. She's got air in her bile ducts from the biliary anastomosis. Her portal vein disappears, then it reappears, and I keep following it here. And I just keep sort of torque. Here's the portal vein, here's the splenic vein, and then here's her malignantly obstructed PD. which if I go left will go, there's the air in it because it's getting close to the anastomosis, which it's just probably around here, right around here. And then you can follow the pancreatic duct out to the tail, just torquing with your left arm all the way out to the tail. There's the, follow the duct, that's the landmark to make sure you're in the pancreas. And then go left, you'll see the kidney there, there's the adrenal. If you keep going left, you'll see the aorta. And then if you keep, there's some ganglia, by the way, over there. Then if you keep going left, you'll see the celiac,
Anand?
and there you go back to the pancreas.
Anand?
Yes.
Thank you very much for your great demonstration. We have to move back to the results of the biopsy performed by Erwin. So I give the line to Professor Doglioni.
Okay, thank you.
Yeah, thank you.
Thank you,
Claudio?
Anand.
Okay, this is the second pass is adequate for diagnosis. The diagnosis is adenocarcinoma, and in this microscopic field you see a three-dimensional fragment composed mainly of stromal component, but with some epithelial cells that are clearly atypical cells going up and down with the focus. So the diagnosis is adenocarcinoma in this case.
Okay, thank you very much, Claudio. So in the room they are preparing for the RCP. Now we go back to Florida. I am looking at Shyam working, so we're going to present the next case in Florida Hospital.
Next patient live from Orlando, Florida is an 87-year-old male with a pancreatic head mass and obstructive jaundice. An ERCP was performed, revealing a distal biliary stricture. Cholangioscopy-guided biopsies were non-diagnostic. EUS FNA at an outside facility was non-diagnostic. Today's scheduled procedure is EUS and FMB.
Julio, we are back again. So you heard the story, pancreatic mass. There is no complications about this procedure. All that we need is tissue. So what I'm doing, Julio, is my scope is now in the second portion. I'm using the Pentax Slim scope, trying to find the pancreas. So here is the portal vein. I'm going to just move. You have to remember something. We are not used to this quality of imaging. So sometimes it's too good to be true. This is just a fantastic pancreatic mass. This is sometimes now I agree why Anand keeps telling that this is unbelievable imaging. So there is this fantastic mass here in the pancreas, and you can see a ductal structure in between. I'm using a core biopsy needle. The doctor who sent this case is pretty good with his procedures. He told me it was just atypical cells and so forth. There is way below the mass, there is definitely a portal vein invasion. It is not very clearly seen here, but you can see this is the vessel. So all that I'm going to do now is to use the 22 gauge core biopsy needle to get a tissue diagnosis. So my needle is coming out, and because it's a slim scope, I'm using the slim scope. It is going to buckle a little bit. So I'm going to have Enrique anchor the scope a little bit for me, and then just going to puncture the mass and then go about 4 times. I'm going to move up. I'm going to move the needle in a different direction a little bit, maybe what we call the fanning. You don't want to come out of the mass if possible. Go back another 4 times. Come up on the top. Now I've taken it out of the mass. I'm going to go in between. We generally try to avoid the duct because it's under pressure. And the objective is just to, and then you change your body a little bit, and then you go another, push the scope in a tiny bit so that we can, and then suck air so that we can see better. And then you go another 4 more times to get tissue diagnosis. So we are going to go straight to the microscope. We know that you're busy, and I have got about 18 EUS procedures on my list. So we did the first pass, and we are going to show the slides right now. Can we show the microscope to the audience? And there we have, I don't think we need to explain anything here. You can see the big cell sitting on the 1 o'clock position. Even for us who are non-pathologists, we know the diagnosis. And there is a lot of atypical cells in the middle, and then the cells falling apart. And that nucleus cytoplasmic ratio is like 99 versus 100%. So this is adenocarcinoma without a doubt. And we are going to make another pass that we did for cell
you
block.
also became a pathologist in your hospital. So I do not know if
Yes,
is going to be very
Julio.
happy by you working as a pathologist.
Yeah, we do. We do about 3,800 EUs now, Julio. We are crossing to 4,000 now. And of our EUS procedures, about 1,500 are FNAs. So we are all well versed with the basics of pathology. So this is a pancreatic cancer, and we will move on to the next case, and we'll bring you when we are ready for the next patient. Any questions?
Is any question to Shaham from the audience? Shaham, we saw you doing with you using the acquire, no stylet, just do fanning. Do you really think there is a role for stylet, yes, no, suction, yes, no? What is your? We've been discussing about the technique. What is your feeling?
No, Julio, I think I used to be a skeptic of the biopsy needle, but I think FNA is only for cyst aspiration, FNB for all solid masses. And when you do FNB, I agree with the Europeans, 22 gauge is better than 25 gauge. And when you do use a 22 gauge, first pass with stylet because the needle is packaged with a stylet. Subsequent passes, Anand has taught us that stylet is of no use, so we never use a stylet. And then there is no role for suction unless you're aspirating a cyst. And then it's a no suction, no stylet, 22 gauge, fan the needle, you're pretty much done. We never believed in off-site assessment, but the new FNB needles, we are coming out with our experience on 3,000 patients, clearly shows you that FNB is probably the way to go. The very first pass you have a diagnosis, or at best the second pass, and then you're all done. And your cell block yield is 90% and above these days with a core biopsy needle.
Okay. Thank you, Shyam. Thank you very much
you.
for this kind demonstration. While you are preparing your next case, we go back to room number 7 because we have seen that Alberto is playing. Try to pull back the stones. At what point are you arrived, Alberto?
I think that the stone now is in the middle portion of the common bile duct. Using a balloon, I try to place the stone in the middle portion.
Dr. Mariani, we had a question from the audience, and it's what about the use of a guide wire through the spyglass to be sure of the right direction in the CVD?
Exactly. With dilated data, it's not the case to use the guide wire, but in this case, I prefer to use the guide wire because it's not stable, the position of the duodenoscope in front of the papilla. So the guide wire can help me to introduce the spyglass into the common bile duct. Tira. So this is a second attempt. It's difficult to maintain a standard position of the spyglass in front of the papilla, okay? Scopia. Oh, we have the stone in the same position. Cholangioscopy, please. Second. Scopia. Via filo guida. We remove the guide wire. Scopia. Cholangioscopy.
Can we have the cholangioscopy image in a big screen, please?
Scopia. Cholangioscopy. Scopia.
So can we have the cholangioscopy, not the endoscopy standard image, please?
Cholangioscopy. X-ray. X-ray, please. Cholangioscopy. X-ray. Cholangioscopy. Scopia. Cholangioscopy.
Alberto,
Yes.
we move to coffee room, and then we can go back to you in a while. Okay.
Okay.
Coffee.
Hello, hi.
Okay. Hi.
Hi, you joined us I've just got the instrument down. We're using the Olympus duodenoscope and Boston Scientific sphincterotome and wire. So it's a short wire, and I'm controlling the wire, which is my preferred technique, and just looking to engage the ampulla. And I just have to echo what everybody else has said. It's a great pleasure to be here. It's a great team you have, and I'm privileged to have been invited to take part in this meeting. It's a great meeting. So I tend to just try and engage, and obviously with ERCP, it's all about getting the right angle, and just trying to make sure we're heading up. So bow up a little bit more, please. And the plan here is we've obviously got a tissue diagnosis, so we don't need to worry about taking any brushings. It's a case of getting access and then achieving drainage. So, and obviously for good ERCP, you're looking to minimize the risks. There's good evidence for wire-guided cannulation, and I think good evidence as well for operator control of the wire. So I'm just trying to maintain that angle and just get that wire to pop up. So at the moment, I've just tried to go in with the wire initially, and the wire isn't quite keen to do so. So I shall try and engage a little bit deeper with the sphincterotome. So there we are. Oops. Okay. And bow up, please. Just a little bit more bow. Thank you. A bit more bow. A bit more bow. Yeah, okay. No, not quite. So in our unit where we don't have the privilege of the on-site pathology, what we would normally do is the FNB, bow up a little bit, please, and then we would also take brushings just to, as once we get access into the duct, just to be sure that we've optimized the opportunity to get a tissue diagnosis. Okay. So I like the angle, but the wire isn't keen to advance at the moment. Oops.
The problem is, I think that this area might be infiltrated, as you saw in the US.
It did look that way,
didn't it? The ampullary area was infiltrated, so you might encounter some problems there.
So I'm trying to maintain the position. What I'm going to try now is I'll just come back a little bit. I'm just going to see if I'll just get the wire to go and just really protrude the wire and see if the wire will find a way through the duct. And it's quite helpful to screen
what's
as
your-
well,
would
just
you-
to see. Oops.
In Newcastle, what's your approach? You try to do FNA, ERCP, and extend the bile duct in those resectable lesions. Do you have the option in Newcastle to have a quite short time for operation? What's your
Yes,
you extend? You do not extend. What's your approach?
Ideally, obviously, operable patients would be fast-tracked, but I think we have the problem. I think a lot of units have that it's easier said than done. So I think it's not common for the patient to get to operation without having had a stent, but certainly we're very keen that they have all of their imaging before they have a stent placed. So the CT, and if they need an EUS, the EUS before they have a stent placed.
Sure.
But the majority will go to surgery with a stent in place. Okay, so I'm going to get a little bit closer. As Erwin said, it's possibly infiltrated. I'm just trying to change my angle slightly. Okay, it doesn't want to go. And then obviously, I'm going to try a little bit longer with this, but then the thought's obviously what we do next. If the wire went into the PD, my preference would be to do a double wire and a technique. If it doesn't go in, then I think we would be thinking of probably doing a needle knife. And
I like the double wire technique as well. It's very helpful.
well,
But
Any question to Kofi or Erwin in the audience up to now?
so I'm going to try and go to the superior aspect of the ampulla. It keeps drifting off slightly towards the left.
You're in a very good position. Probably it's what's happening inside that prevents you.
Possibly, as you demonstrated very nicely, there's tumor right down to the
wall.
duodenal wall. Yeah. And what I don't want to do, I don't want to compress it. I really want to just to be touching it and giving the wire a chance to find the root. And we're using I think it's a JAG wire with a hydrophilic tip. And they normally, if you get the right position, it's a good wire, as I think all of the modern wires are, will find its way up into the duct. Okay, so bow up a little bit, please. Some more bow, more bow. Okay, thank you. It's slightly not the angle I want. I want to be more across. It's a little bit of an unstable position in the duodenum.
And it doesn't penetrate. It doesn't go in.
No, it's not.
It's not going in.
I'm just going to screen I think the X-ray can help to try and make sure that you're orientated with it ideally going near vertically as I have there. So I'm just going to slightly unstable.
Coffee?
So, hello?
Coffee?
Hello.
Hi, I'm Mara.
Hi, Mara.
Just 2 minutes more. We are going to present the last procedure
Okay.
in the room number, number
Umbo,
5.
please. Okay, we'll carry unbow. Okay, so I'm going to try probably for another couple of minutes, and then I think we're going to be plating the patient up and doing a pre-cut, because obviously there's good evidence. You don't want to spend too long doing the same thing.
Coffee, sorry.
Sorry?
We go to another room.
Okay.
Okay.
That's fine. Okay, bow slightly for me.
Next patient is a 54-year-old male with a medical history of arterial hypertension, type 2 diabetes, chronic renal failure, stage 3, and appendectomy. At the beginning of 2018, for the onset of weight loss, hyperglycemia, and abdominal pain, the patient underwent an abdominal ultrasonography with a suspected pancreatic head lesion. A CT scan showed a 37-43 millimeter pancreatic head solid lesion with SMV and duodenal wall infiltration and a peripancreatic lymphadenopathy. EUS confirmed a pancreatic solid lesion with FNA positive for pancreatic adenocarcinoma and 2 peripancreatic lymph nodes, again positive for adenocarcinoma localization. Common bile duct was not involved by the lesion. There was only a slight dilation of it, 7 millimeter. In February 2018, there was an oncologic evaluation that said the patient is not eligible for chemotherapy because of renal failure. And in February, a multidisciplinary discussion opted for a cryothermal ablation and subsequent radiotherapy on the lesion and lymph nodes. Today's scheduled procedure is EUS and cryothermal ablation with operator Dr. Arcidiacono.
So good afternoon. Can you hear me?
Yes, Paolo.
Hi, Julio. So you have heard about the history of this man. So today we are going to perform the first session of cryothermal ablation. So we are going to use this device. Probably you are aware of this. This is the hybrid therm probe by Irby. So it looks like a standard FNA needle. But is really quite large. Is approximately 14 gauge, and this is the tip of the device. You can see the tip. So it has a very sharp penetrating distal part with 2 electrodes. In between those electrodes, we have a bipolar radiofrequency temperature flow, and inside the device we have the flow of CO2. So the device contemporarily perform cooling effect and at the same time radiofrequency bipolar. With this possibility, we have already performed studies that show that we can ablate a very large amount of pancreatic or solid tissue. So the first thing that we do when we prepare to perform this kind of treatment is to test the device in order to see that there are no gas flowing outside. So I put on the water and I just push the button in order to see that there are no bubbles coming from into the bottle, and I feel clearly that the device is cooling a lot. So now I'm ready. I know that the device is ready to perform the biopsy, so I pull back in order to be safe for the instrument. We are going to use the Irby Vio cryo technology that help us to create both the cryo and the radiofrequency. So now I can show you the lesion. Genoa, can you please hold this? So can we go for the echoendoscopic view? So you see, can you see the lesion? Actually, I am in the second part of the duodenum. We have this huge hypoechoic lesion. This is one of the lymph nodes, metastatic lymph nodes, which are close to the lesion, so not distant, not considered as distant metastasis. So this is a lesion which is involving, you see here the vessels, supramesenteric vein is completely involved, and there is supramesenteric artery below. So I start passing the device.
Paolo, do you have any concern on vascular infiltration when you are facing to do a cryoablation?
Well, in such a big lesion, no. we know that the blood flow inside the vessels is usually a thermo regulator, gives you a thermo regular, so it keeps the flow, determines a good thermal protection from the heating. So in all the cases that we have performed, we didn't have any kind of problem.
Paolo?
Tell me.
Sorry, we go in 1 minute in room number 6 with coffee.
Don't
and
worry.
Erwin.
It's okay.
6 centimeter partially covered. Yes,
So
great.
actually, okay.
Hi, sorry, we're back. Sorry, you missed it. We decided. I mean, I think we all know that one of the causes of complications is the length of time that's spent, and so we decided it's better early to move to doing a needle knife, doing a pre-cut rather than repeated attempts at cannulation. And I obviously had the benefit of Erwin's excellent EUS, which demonstrated that the tumor was infiltrating quite low. So we did a pre-cut and have managed to get access. And you can see there's at least a 3 centimeter stricture there, right down to the duodenal wall. And so we don't need to do brushings because Erwin confirmed the diagnosis with the FNB. So we're going to put a 6 centimeter partially covered stent. I'd be quite interested to know what people's views are on lengths of stents for distal CBD strictures. I often think about a 4 centimeter, but very rarely put one. I always feel more comfortable having more stent above the stricture.
Same feeling here.
Yeah. So
what is your concern about using fully covered metal stents in patients with gallbladder inside?
actually, we just need a.
Well, this patient probably doesn't have a gallbladder. I saw some stitches, surgical clips near the cystic duct. I don't know if you can see it now because it's filled with contrast, but I think the patient had cholecystectomy, if I'm right.
I mean,
it's a partially covered. We always say that we have to be aware of these stents, but I very rarely see.
I agree. I mean, it was very. I mean, I've had it happen once, and it was probably the second fully covered stent I placed over 10 years ago, and I haven't seen it since. Having said that, I think we do have to be. If I have filling of the cystic duct, then I'm concerned. If the cystic duct isn't filling, well, it's probably involved in the tumor, so I'm less worried. One question I have for the audience is, using metal stents, there's obviously some data to suggest there's an increased rate of pancreatitis. There's been some interest in doing a sphincterotomy to minimize the risk. We don't routinely in our unit do a sphincterotomy. There is an ongoing study out of the AMC, as a multi-center European study looking at whether sphincterotomies are beneficial to prevent pancreatitis. I'm always worried, obviously, about the risk of a complication with the sphincterotomy.
So how many of you perform an sphincterotomy before placing the stent? Raise your hands.
We'll just wait in case
and who does not perform. Well, here, most of the raised hands were in favor of doing an sphincterotomy before placing the stent. I know that the trial, in fact, we sent out part of the.
Yes. I mean, I think, to be honest, I think the policy. Do you normally do a sphincterotomy? Yes. I think the policy, in this unit is to do a sphincterotomy, so I think sorry. Maria said, I think they normally do. I don't know if Paolo's listening, so.
But I think you did a nice pre-cut.
Okay, let's just go. Stent. Okay.
Let's go with the stent. I think in this case.
We'll stop prevaricating. Yes. No, I think Erwin is right. There's been a little cut there, as you can see.
You did a nice cut here. I think it's.
We don't need to extend it.
We can go with the stent deployment without doing a formal sphincterotomy here in this case.
Okay, so we're using the, obviously, hello?
It's we're just finishing to deploy to insert the stent, so it will take half a minute.
Yep.
Half a minute, please, Erwin. Just wait half a minute.
Okay.
We go back to the room number 5 for the cryotherapy.
Okay, half a minute. Here we are.
Treatment.
Okay. Here we are. We are finishing.
Okay.
Okay, so I'm just going to screen so we can see the stent going up. And obviously we're looking for the marker at the bottom end.
Yeah, here
the
we are.
yellow coming up. There's the marker. Have we seen it yet? There it is. Okay,
There it
so
is.
come back. We've got a lot of stent proximal, so I'm happy about that. And we'll start deploying, please. Just nice and steady. And I tend to just go by, you're obviously going to get some, so we're just watching for that yellow marker going up. If we stop a second, I'm just going to screen.
Another one?
Okay, so we're
okay,
well
that's
up
very good.
there. So just coming back down a little bit. Okay, carry on, please. And obviously we're just doing it in stages, watching for the proximal extent. Stop there. Just check again. So we're still nicely above it. I
it's
can
fine.
afford to come down. Okay, please carry on. Okay. There we go. Yeah. And we'll just deploy it now. Yeah. Yeah.
Fantastic.
Okay, great.
Very good.
Thank you very much. So, and we can see the wasting of the stent, and it's in a nice position,
It's
I think.
a very good position.
Okay, and we'll take everything out.
Thank you, Coffee. Thank you. Very nice demonstration.
Thank you. It's just a bit stiff. It's quite tight.
Yeah, it's
Okay,
tight.
we'll just wait a minute.
Until it dilates a
Yeah,
little bit, yeah.
open up a
Andiamo
little
sulla
bit.
5. Paolo?
Yeah. Here we are again.
We are with you, Paolo, again.
So I have tried to find out a good position. This is the needle, this is the lesion. So I'm trying to go and penetrate the lesion. Okay. You see how it goes clearly inside the lesion. So you see perfectly the tip of the needle. These are the electrodes. This is the distal part. So I'm fairly inside the lesion. So now I can treat the lesion. It's not working, but okay. Now you see that I'm treating the lesion. I remove all the settings so you can see clearly what's happening. You see that there is this effect of burning. These bubbles are coming. As you know, the bubbles are not a demonstration of the effect of the fact that there is a burning. The bubbles is just because of some heating, but if you want to see the clear effect of the necrosis, you need to perform after 48 hours, 78 hours, or a CT scan, or we usually prefer now to perform MRI with diffusion. You see the bubbles are increasing in the lesion. We are very stable, and if you can focus on the computer that we have there, this computer shows us with these lines the efficacy of the treatment. When the two lines will collapse after a while, this means that impedance of the tissue rises up to a level that the machine cannot work anymore. The treatment is not more effective. At that time, the machine will stop automatically. We usually preset the machine to stop at 3 minutes, but sometimes, particularly for bigger lesion, the machine can work even more. So now we will wait 3 minutes. If the machine will work, we can continue applying until the machine tells us that the maximum of the effect has been reached. So you can see here that the lesion is very. You can see clearly here the efficacy of the treatment. The graphic on the computer are still working very well, so we need to wait for a while just to have the treatment. Tell me.
Paolo, just a question. How many sessions do you think it's in these big lesions How many sessions are you giving the patients? Are you doing just one shot?
No,
you just
actually-
do it depending on MRI that you do subsequently, or you just according to the size or your expertise, you decide to make it every 48 hours?
Yeah, actually our protocol is scheduled to perform a minimum of 3 sessions. We do 1 session every month. So this is the first session. The patient is going to perform. Okay. The machine has stopped automatically because it reached 3 minutes, but was still working. So I continue just pushing the pedal. I can continue treating. As I told you, we usually schedule 1 treatment every month until we reach a good efficacy. We have in our preliminary trial, we have shown that at least during the first attempt, we are able to destroy nearly 30% of the entire lesion, particularly in this big lesion. It is impressive to see the CT scan or the MRI because there is a big hole, necrotic hole inside the lesion. You see that it's continuously flowing. And you see how it works here. So now we saw that there is a movement of our curves, but the machine is still working. So this is because the lesion is quite big. So now we reach 4 minutes.
And do you have any data on systemic response to this therapy? Because there's something told about that is not only local effect, but we can also try to get some kind of change on the environment of the lesion. Do you have any data?
So we are during these days we are running a trial on immunomodulation, on the efficacy of immunomodulation and immunoresponse induced by this treatment. It is an ongoing trial. I don't have the result until now, but we are working on that. As you can see, the machine has stopped out automatically because the graphic, the 2 big lines, the red line and the blue line are collapsed together, so the machine stops automatically and we finish the treatment. So I can remove the needle. You see the needle, I remove the needle very easily. You need to wait for at least 2 or 3 seconds after the end of the procedure because the needle tip is absolutely cool, and so sometimes it is impossible to remove the needle. But after 2 seconds, the needle is warming automatically, so then you can remove it very easily. So you can see here, this is the lesion that we have done. So by endosonography, the lesion seems to be like that, but we will see, because we know that the endosonographic evaluation after the treatment is not so precise, so we will wait for the results of MRI and CT scan. In the second attempt, in the second session, I would try to go for this part. So next time, I will try to go this part because this part seems to be completely heated. You see how the pattern and how the echogenicity of the lesion has changed during the treatment. So next time I will treat this part. So now the treatment is finished. So I think that we can go back to the other rooms for the other cases. Thank you very much.
Thank you, Paolo.
Yeah, it is.
Alberto? Alberto?
Alberto, we have you online.
Have a long procedure.
Okay.
We are coming to treat, reduce the volume of the big stone. The consistency of the stone is hard, so is long the time required to fragment the stone. We have some damage of the surface of the mini probe. The vision is not good. Scopia. Now it's better.
Alberto?
It's not possible to establish if the tip of the mini probe is in contact with the surface of the stone or just some millimeters far.
Alberto?
Yes.
We move to the last case in Orlando. So you complete your examination and then you give us the final result.
Okay.
Maybe tomorrow. So we're going to present. I'm going to present the last case in Orlando. I cannot see. If you push me out, I don't see the slides. Okay, this is a 69-year-old male with a pancreatic head cancer, completed chemotherapy, and the patient will undergo preoperative radiation therapy. And so today, Shyam will show us the US-guided fiducial placement. Hello, Shyam.
Hello, Paulo. You heard the story. This is a little tough case, and the anatomy is a little complicated. It's a low-lying uncinate mass, and you got fluoroscopy and EUS on the same image. So you can see my scope position. It's beyond the second portion, and it's beyond the metal stent because it's a low-lying uncinate. I've got the Covidian fiducial system that comes preloaded with the 2 needles in place. So for a second, can we show the hand, if possible, at the system? So this is a very tailor-made system. It's all inbuilt. It's 22 gauge. I'm going to get all that we have to do is to puncture the mass, and then we pull back on the hub, push the stylet for placement of 1 fiducial. Second hub is moved out, and a second fiducial is placed. And then if you want to place more fiducials without removing the assembly, the top portion comes out, and we can insert through the same platform 2 more fiducials that is inbuilt. So now let's go back to EUS to look at this mass, and you can see this is a low-lying uncinate mass. And on fluoroscopy, let's play fluoro, and I think there's a small vessel in front. I'm going to try to avoid it and torque my scope a little bit. Enrique, can you please push the scope in a second? There you go. And then I'm going to just get my needle here and just go straight in. And on fluoro, you can see it much, much nicer. And if you want to see the needle, you just move it back and forth. I'm right now in the middle of the mass. Going to push in a little bit further. And then let's deploy the first fiducial, Enrique. We don't need fluoroscopy for these things, but the advantage is that if you have fluoro, you can see it very, very well. So I'm going to just move my, see that? The fiducial got disengaged. So now all that I have to do is to turn my shoulder, retract the needle a little bit, go to a different part of the mass, and then you're going to puncture again, okay? And we are in the substance of the mass. Let's go and place a second fiducial. And Enrique is now pushing the hub. And the second fiducial is getting deployed. Is it done? And then I'm going to pull back, and you can see that the second fiducial is deployed as well, because if they can't target the stent because the stent is so long. So we place 2 fiducials over which the radiation radiation therapy can be delivered. So let's get another 2. So we are done. If you want to go to another room, feel free to. I'm going to place 2 more fiducials through the same platform. So as you can see here, all that you need to do is to just pull this out and get back another set of fiducials, and then so that we have 4. Usually the radiation oncologists at our campus ask us to place a minimum of 3 fiducials in each patient. So we placed 2, and this is all comes very beautifully inbuilt with a safety mechanism. And we're going to place 2 more at hopefully a different location. So one of the challenges is in the uncinate portion. So the needle gets bent easily. So now I'm going to deploy the second set. Have fluoroscopy, please. And then there it comes out. Use a little bit of elevator to puncture the mass. And I'm deepen. Okay, let's go and place the third fiducial. And you can see that the tip of the needle is really, really bent. All right, done. And I'm going to pull back my, okay. Sometimes you can get hung up on the substance of the mass a little bit. So it's important to just wriggle it out a little bit. And then if that doesn't work, you got, there we go. So the third fiducial has been deployed. I'm going to retract the needle, try to see if I can space it somewhere a little different. I'm going to go deep down now. And I'm now very deep into the mass. Okay, let's place the fourth one. It all seems to be lining against each other. It's because we are seeing it on 2-dimensional view. Okay, let's go. And then we are done. So Paulo, we are done with our fiducial case here.
Saham, is the same platform as the standard needles?
Yes, it's the correct. It's just the Medtronic needle is a single platform. And then you can just exchange your fiducials or your FN. The nice thing is you can just do everything with a single platform. You can perform an FNA, you can perform a neurolysis, you can place a fiducial without removing the sheath coming out of the scope. And you just can accomplish different mechanism by moving into the hub of the needle, whatever accessory you want to place, including a wire if you need to perform an intervention. So.
Nice demonstration.
Thank you.
So Shyam?
Yeah, Paulo?
Thank you very much for this great demonstration of this afternoon. Was fantastic having you with us this year as well, like last year. Hopefully we will connect with you next year as well.
Thank you. Thanks so much, Paulo. It was a pleasure being there.
Thank you very much, and thank you to all your team. Thank you very much.
Oh, thank you. Thanks so much.
The afternoon live demo is finished, so we can go back to the auditorium for the next presentation and lectures. Thank you very much, and see you tomorrow morning from our endoscopy service.